Good morning. I'm Dr. Wiley and welcome everyone to our monthly live peripheral webcast from Mount Sinai Heart. We're live at www.peripheраlinterventions.org. Today is Wednesday, May 23rd at 8:20 a.m. at Mount Sinai Medical Center Cardiac Catheterization Laboratory in Manhattan, New York. Dr. Krishnan is in the peripheral suite getting ready to take on a challenging case live on the web. Please send us your questions to info@peripheраlinterventions.org, info@peripheраlinterventions.org, and we will answer them live. I would also like to invite you to our 15th Annual Complex Coronary and Vascular Cases Symposium in June 13th to the 16th at Mount Sinai Hospital here in New York City. For registrations, go to cccsymposium.org, cccsymposium.org. Dr. Krishnan, good morning.
Wiley, how are you?
Good, good. Please introduce us to your team and give us a brief history of the case that you're going to be presenting us today.
Well, I'd like to welcome everybody to the Cath Lab here at Sinai. It's really a pleasure to have all of you here. We're starting quite a difficult case, and I'll give you a little bit of a background on it. But before that, I'd like to introduce my team. We've got Ricky, our technician, Elizabeth, our nurse practitioner, and of course, Ray, our interventional nurse practitioner, who is so essential to our program. We've got a case. Can you put the slide up, please, for me? We've got a patient here who is a 73-year-old male with past medical history of 6 sinus syndrome, status post pacemaker. He also has had ischemic cardiomyopathy with an AICD placement. He's got peripheral arterial disease with bilateral SFA stenting, who basically returns with recurrent left calf claudication. He ambulates less than 2 meters, basically Fontaine 2A, and so he's not a candidate for Platal. He tried exercise therapy, has failed, tried stenting, has failed, and now is here for in-stent restenosis, which all of us really are going to face in our practices. So we decided, we did a diagnostic angiogram, we decided to bring him back today. And when we brought him back today in the morning, we're on a little late because the patient was not feeling well on the table, a little bit of CHF symptoms, which we were able to treat with some Lasix, and he's very comfortable at this moment. So I'm going to limit my dot, and that's why I want you to bear with me, but obviously if you can't see something, we'll definitely show it to you. So our plan of therapy for this patient has been very, very clear. So what we're going to do is we're going to get contralateral access, go up and over with a 7 French pinnacle destination sheath. We've got that done. And I'm going to show you the angiogram. Ray's going to go scene minus here, and I need the screen up on the scene minus. So the angiogram, we just took, again, a very brief shot of the SFA. You can see here we're injecting from above. You can see the dye come in the SFA, and then the in-stent occludes. You see the profunda filling, and distal. It's a short segment occlusion of a long SFA stent, approximately, I would say, the entire length of the SFA. Plus, please. The reconstitution of the SFA occurs at the above knee pop. And then you have a distal popliteal segment, which you'll see coming up at this level, which is pretty much a straight shot and running into a single vessel anterior tibial artery. Now, I just want to show you the length of the stent that we have. You can see here's our 7 French sheath, and you can see the SFA stent overlapping stents, whatever they may be, all the way down to the distal. And so what we decided to do was, whatever we wanted to do, we felt that debulking is a good strategy here prior to cutting balloon or stenting. So what we decided to do is place a filter. And I know this is one of the challenges we all place. And here we placed the EV3 Spider filter, which we chose a 7mm filter based on the size of the popliteal, which is around probably 5 to 6. And it's a good habit in these type of cases to go ahead and place a filter distally, because these restenotic cases are really a mixture of not only in-stent restenosis, but also thrombus overlying the restenosis. So embolic potential in these cases are very, very high, not only because of the breakage of the plaque, but also of the overlying thrombus that may be present or clot that may be present chronically, leading to the occlusion. Now, as far as our anticoagulation, we went ahead with bivalrudin. The patient has been on chronic Plavix, and we're continuing that right now. How we crossed the lesion was very simple. I didn't show it to you because it's kind of simple. It's in-stent restenosis, so you don't have to worry about getting subminimal. I just took a 035 Trailblazer catheter, which is made by the Covidian company, EV3, and we just pushed it right through the occlusion, And obviously, because the stent, it stayed within the lumen, pushed it all the way down to the distal pop, and then we placed the stent. I mean, we're very paramount here, not to give too much dye because of what happened to him earlier. He's very comfortable lying down. He's urinating. He's got a Foley, so we're going to try to limit our dye. Now, as far as the plan of action, I just want to throw it out to Dr. Wiley and the audience, if you want to go ahead and chime in, is how you approach. But I'm just going to tell you our plan so you go ahead and understand. What we decided to do here was use an intravascular ultrasound first, because I want to characterize what's happening in this lesion. Now, is it fibrotic? Is it fibrocalcific? What type of lesion are we dealing with? Based on that, I'm probably going to do an atherectomy. And here I chose a Pathway Medical rotational atherectomy. It's called the Jetstream. I know it's no longer owned by Pathway. I think it's owned by Bayer now. And so what we're going to do is we're going to go ahead and do this particular device. Now, the device comes in multiple different sizes, and their latest sizes, it's 2.5 to 3.4, which is their burr size. And this is their latest device. It's a large burr as compared to their old 2.0 to 3.1. So therefore, it also is 7 French sheath compatible. It's rotational. It has two sizes, blades up, blades down, which we will demonstrate in this. So the advantage of this particular device, obviously, is because we're going to go ahead and do a aspiration thrombectomy as well as a rotational atherectomy. So hopefully the theoretical reasons would be to minimize the embolic potential because of the thrombus, but we're double protecting ourselves by having a filter down. As far as the filters are concerned, you could probably use any filter here as long as the wire is sturdy enough. Other technical caveats for all of you out there is 2 things. One is you are going to lose pressure when you go up and over, so you need to have an excellent nursing team like we have here, letting them know that pressure is going to drop if you follow pressure. And other than that, I think it should be quite simple to do. So I'm going to go ahead and do an IVUS. I'm going to let Dr. Wiley talk about different approaches for in-stent restenosis.
Dr. Christian, while you're doing your procedure, without probing on that lesion, do you think this is all smooth muscle cell proliferation, or you think that there's some thrombus burden, and that's why you decided to put a filter and perhaps use this rotational atherectomy with aspiration capability?
You know, Dr. Wiley, one of the things that we've seen is that we're seeing a lot of stent fractures that you really don't see very well fluoroscopically. I know that seems to be the gold standard. I can show you an example after we're done. You can see here, I'm probably in the middle of the lesion. As you can see, if you can show the IVUS, guys. Can you show the IVUS live, or you have to point the camera? So as you see the IVUS, you'll see very, very clearly that there's pretty much a circumferential type of plaque that's around, right around here. And this is a great example. We have our IVUS people here who are going to measure the imposed plaque burden as well as the circumferential area.
Dr. Christian, we don't see the IVUS imaging. Oh, yep. Now we do.
Okay, so now as I advance it, you can see right here, you've got a very, very calcific, the little bit of movement, possibly thrombus in there. As you can see here, double density shadows with movement, as you see by the pointing of the pointer. Somebody's very kind enough to show that there is a little bit of flow through this, and you can see there's a layering effect that you can see, especially on the side. So I'm personally, after doing a lot of IVUS on these cases, I'm very, very convinced that you have a combination disease in these particular types of lesions. So the combination disease is going to be, yes, your typical in-stent restenotic lesion, as well as you can see as we go forward, it seems to be more ISR. I mean, the occlusive process is clearly going to be your ISR, but then I think the final process is going to be some overlying thrombus. And what I always worry with the proximal area, where the above the occlusion is where you have a lot of stagnation of the blood, and I really think that you're going to have some thrombus formation. Now, there's a lot of questions I know last time about antegrade versus up and over approach. I mean, we've been able to take the antegrade approach, the up and over approach for 95% of our cases. And I think in something like this with a proximal SFA stent, it's probably reasonable to go up and over versus antegrade. The other question is, let me just show you the device here. If you guys can zoom in. I don't know if you can see this. So the device itself is a rotational burr, okay? And the burr has an aspiration port, which you can't see. And I don't know if they have the animation. Do you guys have the animation? Okay, we'll show you the animation in a second after we're done. You can see that there's an aspiration port as well as obviously the rotational burr. So when you go, press the button, please. When you press the button, you'll see that it'll actually spin. Yep, go ahead. You see it spinning, and then the blades will go up and down. So it's quite an effective device. And I'm going to go ahead and do it in this particular lesion to demonstrate how we do it.
So you can utilize the device with blades down and blades up?
Yeah, that's what we do. We actually do it in two particular ways. We go blades down, blades up. Now here we have a large SFA with a lot of plaque. So obviously two things I'm concerned about is the movement of the filter. And there I'm going to rely on my trusted friend Ray here to make sure that it doesn't move as much as possible. And a lot of times what we do is to be really paranoid. We look at the filter as we go up and over. And you know, the advantage of the Abbott filter is that it doesn't move because the wire is what moves. But a lot of times with that, you can get casual and can have wire perfs. Pull the wire, please. So here we're going to go very, very slow because it's tight as we go in. Ray, walk with me, grab it, and walk with me, okay? Okay. So as we go, we're going very slow. Right now there's no, I'm going to stop, let Ray catch up.
So Dr. Christian, the reason you're using the Abbott filter is because it's independent with the wire, catch up. Or is there any other reason why you're using it?
I'm not using the Abbott filter here, Dr. Wall. I'm actually using the EV3 filter.
Okay. So this one is attached to the wire.
This is attached to the wire.
Okay.
And I think you could use both filters. All the filters have their advantages and disadvantages. I'm just going up, as you can see, I'm up and over. And we have not moved the filter at all, so I just have very little to go. So I'm just going to go forward. Now, normally we don't go up and down like this, but I'm just showing you that we just want to be a little more careful and not nonchalant about this particular part. So I'm just going to go down to the area of occlusion, right, which should be right about here. And then I'm going to run it through very, very slowly. Now, one more step I want to show you is the wire. The beauty of this device is that the wire will not move because of this loop that you make. So you make this loop that's nice and large. Now the loop is going to allow the device to track on the wire without it moving. And if you can show me the device here, there's two buttons. There's blades up and blades down, and then there's something that we call as, for lack of a better word, what's the word that they use? Rex, the Rex mode. But you do a lot of rotablation here, and we just call it dyna and rota, so it's much easier for us in our lingo to understand. The button itself has two. The bottom button is the Rex mode, which is like a dyna mode if you're a rotablator, and the top mode is a rotablation mode. I want you to show the pressure so everybody can see the pressure. So when you see the monitor, the pressure becomes damped, okay? And so we're going to get ready to get going. Ready, guys?
So Dr. Christian, so this device works...
I can't hear you, Dr. Wiley.
This device only works in 014 wires, or?
It only works in an 014 wire. Ready? Okay, on. So we're going to go very, very slowly through the lesion. And you can see right here, as it starts to decelerate, you want to be very slow as you go through, which is what I'm doing. And if you could show the tubing, guys, you'll see exactly how the tubing looks. There's aspiration as well as obviously lavage. And you're not going to, okay, stop there. So when you hear that beep, you got to go ahead, stop for a second, you go on Rex mode, which clears it out nicely. And then you go ahead and start again. On. And again, you want to follow a nice hacking type of procedure. Not too fast, not too slow. Just let the blades do their work. Okay, you want to go up and down.
So you're doing what, about a centimeter per second, or?
I'm going to just try, it's a feel thing, Dr. Wiley. I'm really feeling how this feels in my fingers. It's moving very, very nicely right now. And I'm just going to go forward. Again, okay, and when it says that, Ray's going to Rex for a second. Come down for me. And now this should pretty much be the end of the occlusion here. On.
Dr. Christian, do you have any concerns that the blades may get stuck in the stent struts, or are you confident that that would not be a problem?
You know what? This is an off-label use for this device, and I should have said that in the beginning. This is an off-label use for this device. This is not an on-label use. But in this type of situation, when you have such diffuse in-stent with plaque formation, I really think that it adds a lot of value. So obviously, we do off-label use of all devices, a lot of devices in cardiology. We've been stenting off-label for many years, and you know, it's not that it's right or wrong. We're just trying to do what's the best for the patient. In our opinion, right now, I think debulking works really, really well. Number two is that we could also use other atherectomy devices. The Silverhawk atherectomy device also, which is a directional device, gives you more of a risk, again off-label, go forward, on this type of lesions because then it can really get stuck within the stent. So this particular device doesn't really get stuck. It moves really, really well. I just want to show you the filter to demonstrate that the filter does not move, which is kind of cool. Now what we're going to do is we're just going to walk this back.
Dr. Christian, any risk of perforation with this device?
In this particular case, no. And the only real risk is embolization. Okay, good. And I really think that that's why we've been extremely paranoid with the filter, as you can see, as well as with our technique. So we're going to go blades up now. Now I'm going to press the button.
Any concerns on luminal gain?
That we're going to show you IVUS, and for the sake of time, I'm just going to go forward. So I'm going to press the button for blades up, and I'm going to mag up here to really show you the blades going up, okay? Okay, blades up. So you see the blades came forward, see? And you can see how it is. Now we're just going to go very slow. I usually move till I get resistance, and then go very, very slowly. Like right now, I'm okay. I'm going to go back and forth. See the little deceleration that you heard? That's also because we're inside plaque right now. There you go. When it starts moving like that, that's actually a good sign. Go ahead, Rick. That's actually a good sign because it says that you've broken through the lesion. Now we're going to go down a little bit more. A little fast. So you want to be a little bit slower. Okay. Put it on corner. Okay. And you can see very, very clearly there how it moves.
Is your plan of action is a standalone rotation atherectomy, or would you be planning on doing balloon dilatation afterwards?
You know what? I think that's a great question. And I think, you know what, here we've done two passes. C minus, right? We've done blades up, blades down. And what I want to do is really go ahead and look at the prior film, again, limiting the dye that we've given so that we don't give too much dye to this guy. And we'll make sure that we have, we've covered the area that we wanted to cover. So you figure right around the center of because of the commotion, glow tape wasn't put on this patient, but right around the proximal edge to there, I think we've clearly covered that area and more with both the blades up and blades down. There's another lesion a little bit distally, if you can see, and the question is whether we need to go down there, which I think I'm going to go down there now. Right where it's overlying the bone, you'll see there's a short little lesion of restenosis right there. So I'm going to probably head down there now and take care of that. Hold on. So right over the bone, which is right about here, right? So I'm going to, Dinah, I'm going to come down to about here. Okay, ready? Ready. Now we're going to mag up again. Okay, go. So there you're going right through this one. A little bit of resistance, right? Very slowly. Forward, right? See how it popped through, Dr. Wiley?
Yep.
So you have a really, really tight lesion here for sure. Off. I'm going to go blades up again. On. Blades up one more time. Again, letting it work. And you can see how there's that differential cutting, how this particular device goes from one side to the other. But then when we pull it back, it goes very, very nicely down the center of the loop.
So I'm assuming the risk of embolization is with the blades up. Am I correct? Or
I'm sorry?
So the risk of embolization is higher when the blades are up, or
I think there's embolization occurs with everything that we do in peripheral intervention. I think as far as we're concerned, I think in this particular device, the embolic risk is present whether you're blades up or blades down in any device that you do. So therefore, here, what we're going to do, so I think having a filter is helping us to minimize that risk or at least capture what we embolize. That's one. Number two, the other point also is to prevent it before it happens. If you think it may embolize, I say use a filter. We have an indicated filter in the EV3 device. You know that in the definitive calcium, it actually got the approval as an indication for peripheral use. All the other filters are not peripherally indicated. So therefore, if you want to use the EV3 filter, you have an indication behind it, you can go ahead. But I think all filters are effective as long as the sizes are appropriate for the vessel. As far as the dangers of using a filter, obviously movement of the filter, Obviously, a dissection of the distal artery where the filter is can be a problem. Rarely you may get spasm. So now that we're done with this, I'm going to show you, we're probably going to have a great number of particles inside this filter, so we're going to be very careful in taking it out, and we can talk about what else we can do. Okay, ready? So when we take it out, I always watch the filter. I'm going to have Ray go ahead and Rex, which is going to be the mode. I'm going to be very slow, because I really want to be disciplined in how I take this filter out, this device out. Because I'm assuming, so 1 second, stop. I'm assuming that there is absolutely a lot of debris inside that filter. You're going to see it decelerate as it comes to the arch. It'll probably stop right there, which is normal. Go ahead, Rex. And then it starts again, which is, again, completely normal. And now we're out. So now that we're out, now we wipe the wire down. And I'm going to run the IVUS through one more time, but I'm going to just take a picture for myself to see what's in that filter. Let's see.
Good.
Ready? Again, we're going to minimize dye, so I really beg you all to be patient with me. Let's withdraw and make sure we don't have any clots inside the system. The other thing, just to make sure, again, you had a long run time, make sure there's no clots. Obviously, with bivalve root, it's a lot less. Come forward.
Dr. Christian, is there any indication for cutting balloon or scoring balloon or just plain old standalone balloon angioplasty in this case?
I think it's absolutely, you can do any of the above. Inject. You can do any of the above in this particular case. And I think I'm going to have to inject again because we've got a lot of saline. And I think it's just a preference on what you want to do. I know people who would re-stent this, who would do anything different. You can see right there, there's great flow. And the filter actually looks pretty empty. Maybe there's some debris inside the filter. So you can see how we also place the filter in a very healthy segment of the vessel. Now I want to do a low mag DSA shot. Forgive the Foley across the... No, it's fine. See, and you have a nice lumen.
Very good.
You see?
Yep.
You have a nice lumen. You've gotten rid of that overlying thrombus, and I'm going to go ahead and run the IVUS through, which I think, again, we've learned a lot from the IVUS in this particular kinds of lesions.
Dr. Christian, I'm glad you showed the filter. What would have happened if the filter would have been full? Would you retrieve it at the end of the cage? Would you try to aspirate it? What would be your approach?
I think that's a great question. One of the things that we do here is we go ahead, take a picture of the filter before we do anything. This way, we feel that the filter is full. Any further manipulation may cause embolization. So therefore, we go ahead and we go ahead and aspirate the filter. There's multiple different ways of doing it. My good friend, Dr. Babayev in NYU, gave us the great idea of going up with the 018 Cook sheet up to the popliteal artery and then aspirating through that. So the 018 Cook sheet goes on an 018 wire, so obviously you can go on an 014 wire if you need to, go up and over. But that's, again, that could also fits right inside the 7 French sheet because it's 5 French. That's one thing you could try. The second thing we've done here is just gone with a coronary guide. We go ahead with a 6 French multi-purpose guide over either a new mailman or this current wire that we have, get all the way down distally and just aspirate using the actual Pronto mechanism of the two aspiration syringes. We aspirate going forward as well as coming back. We do that a few times. Angiojet, we felt, has not really worked well in this particular situation because I think this is not so much thrombus, but a mixture of organized clot as well as debris. So therefore, I think active aspiration with the suction catheters or the guides are what really helps. Now I'm going down with the IVUS catheter, and I'm going to go approximately to the area where we saw we were around lumen. Go ahead, Greg. And you can see this is the area we were completely around the catheter. And are we live? Okay. And as you see, I'm pulling back very, very slowly. You can see we've got a very impressive lumen. I'm really, really impressed with this device. You can see that the device is, compared to what it was, has given us a good lumen. And you can see all that other stuff, that junk that was laying around is really gone and really kind of aspirated out.
No, I agree. There's clearly a significant luminal gain.
Significant luminal gain for sure in this particular case. And clearly you see that the other free-floating stuff is all gone. You can see that there's some dissections, as you see right here. which again we expect with any type of directional or rotational atherectomy, which can occur. And then you see areas where you have absolutely no clot or no debris or no stenosis.
Dr. Christian, any role for laser or orbital atherectomy? What's your take home on that?
In my opinion, there is no role for orbital atherectomy in in-stent restenosis. Laser, as you know, is currently has been historically used in in-stent restenosis, and they're currently doing a trial, which we're not part of, on in-stent restenosis. You know, it's again, I think the general concept is that debulking is very, very important in these particular lesions, rather than just pushing the plaque aside. So here we've debulked it. Now I think we can do whatever you want to do. I think this is where, first of all, you've debulked it. You can now go with an angioscope balloon. You could do whatever you want in this particular lesion. So what I'm going to do is I'm going to go ahead and go with an angioscope balloon. I'm going to go with a 60100 angioscope. Now the nice thing about these balloons is obviously the capabilities of the blades, or of the scoring, as they call it. But I think the other important thing is that you have sizes that are large enough. The Boston Scientific cutting balloon is a phenomenal balloon, but the peripheral sizes are very, very small. In this particular device, now you've actually debulked the lesion quite well. You've aspirated the thrombus. You've prevented embolization. The patient, thank God, is stable. Now I just want to get a nice luminal gain, which is going to give me a nice result angiographically. So we've got the angioscope balloon right here, which is again made by the company Angioscope. And I'm sure a lot of you know about it, but I'll just show you the balloon before we put it in the body. It's a large balloon, the 100-millimeter balloon. They used to only come in shorter sizes, but they recently have come in larger sizes. And this particular balloon, I'm just going to take it out while Ray gets things ready and just show it to you. Thank you very much. It's a large balloon with elements. I don't know how it shows against my finger. With let me use something darker. Oh, here we go. With elements, coil elements around the balloon, wrapped around the balloon. You see it there, right there. You can see it very well. So it's got these wires that are around, which are going to score the balloon. There's actually quite a few companies that are interested in this. Obviously, cutting balloon was first originated by Boston, but then Angioscope came along, and now they have something called as the chocolate balloon, which is kind of interesting, which they say provides pillows to prevent dissection. But here, I think the point of me using an angioscope is it's in-stent. Historically, we've used angioscope in in-stent restenosis. It's 014 compatible, so I'm going on an 014 wire, as I did with the Pathway Medical, with the rotational device that I just used. I keep calling it Pathway Medical because I used to work very closely with the old company. And so I think this is a good balloon to go with. Rail?
Dr. Christian, you mentioned that you were using bivalirudin in this case. Any role for heparin, or do you use heparin in any case?
Well, you know, our heparin use has really gone down. I mean, we are, as you know, a very busy interventional lab, and our director, Dr. Sharma, and our current director, Dr. Kinney, have really migrated more towards bivalirudin over heparin. As you know, the data does support the use of bivalirudin in the coronaries. In the peripheral, bivalirudin, you know, has been studied for safety by Dr. Ali and Dr. Walker down in Louisiana. So there is safety data with bivalirudin, and we've now done probably, in my estimation, over, I would say, at least 2,000 cases on bivalirudin, and God willing, we've had no problems. You know, these cases are longer, so I know that obviously, you know, the worry of anticoagulation, checking ACTs are an issue. And I think it's a preference. I really don't think there's a right or a wrong. Go ahead.
Now, if you were intervening on an iliac or a renal or a carotid, would you have used bivalirudin?
Sure.
What?
Go up slowly. Dr. Rubin has studied bivalirudin in the carotids. As you know, it's been studied. But you know, as far as what our protocol here is, we use heparin in the renals, in the carotids, as well as in complex iliacs. Or I should say all iliacs. Because I think once, if God forbid you do perf in this particular vessel, you're going to have a lot of trouble, obviously, reversing bivalirudin. So now, and also in complex subclavians, we also use heparin. So it's not that we only use bivalirudin. We use bivalirudin in the majority of in all of our leg cases, I would say, and a lot of heparin in the other areas.
So use it selectively in areas that you can compress.
Yes.
Okay.
Yes. So you can see we're going up with the balloon. Go ahead, 7. 8. Now we go up very, very slowly with this balloon. It's a 6-millimeter balloon. We try not to come out of the stent strut, which we've done very well here. Down. So now we go ahead. We injected there. We're going to do the whole length of the stent.
I'm sorry, Dr. Christian, what was the length of that balloon?
It's a 100-millimeter balloon.
Okay.
So when I pull it back, I'm going to try to overlap it a little bit. Go up again. And I think when you do the atherectomy with the jet stream device, it really allows for nice balloon expansion, as you'll see. You know, because these lesions are very, very fibrotic. These lesions are very, very fibrotic. But you can see here with just 5 or 6 millimeters of atmospheres of pressure, we're getting good expansion. But since we're inside the stent, I'm going to go up. I want to implore the cardiologists out there not to go up very, very high in these balloons unless you're within a stent, because this balloon is a very aggressive balloon and can cause perforations. Down.
What's the nominal pressure for this balloon?
Nominal, I believe, is 8. We're going to check it. It is 8. So we went up to 8 on each one of the last 2 inflations. I'm going to go up again. Again, I'm being very, very careful not to move that filter. You know, that filter is my friend. And go up again. I don't want to move that filter and cause either a dissection or spasm or an embolization. Now, this is an area that we really did not do a lot of pathway medical atherectomy, so you can see the expansion will be a little bit more difficult. But I felt that there was no reason here because there was, there was no occlusion. So we're right now at 4, we're at 6, we're at 8, we're at 10. We're going to go up to about 10 atmospheres. So it took a little bit more pressure to go ahead and open it up here than it did down below. The luminal gain with pathway, especially with the new improved jet stream atherectomy, is phenomenal. I'm very, very happy with the luminal gain, and also the capability of it aspirating is very good as well. Down.
Dr. Christian, you mentioned that the patient was somewhat unstable when you started the case or prior to the case. How's he doing?
Well, he's obviously got CHF and other things, and we can't understand why he went into pulmonary edema prior to, but it wasn't obviously overwhelming pulmonary edema where he had to be intubated or anything. We were able to stabilize him with some Lasix and some morphine, and we talked to him, and he's very comfortable, and he said we wanted to get this done. He'd been waiting for a little while, and now he's obviously doing very well. Good. And again, the other key is limitation of the dye. I mean, if you guys have seen, we've done this entire case with probably, 3 pictures? So it's not impossible to do peripheral interventions with extremely, extremely low dye use and very, very fast. We started this case at 8:15. It's not even 9 yet. We're basically done with this particular case, barring any unforeseen embolization. Down. So
you use what, 30 cc's or 40 cc's of contrast?
We use about 40 cc's of contrast, very, very little. And we just, again, we obviously have the ability because we have a stent, but I think it's important to plan these cases out and really think things through. What are the things that you want to do? How fast do you want to do them? We are one of the busiest labs that I'm aware of. We do approximately 20 interventions a week in peripheral in 2 days, 2 to 3 days. So I can tell you that in order to be able to do that, you have to have a protocol-driven, algorithm-driven approach to these cases. And I think it's anticipating what's going to happen. In this case, we anticipated embolic potential is high. We went ahead. We used extreme caution and discipline in not moving our filter. We watched the filter as the pathway, which is, I keep calling it pathway, and I apologize to the company, as the jet stream atherectomy went up and over. And you could see that, I think that's the only way to approach these patients. These are complex patients. They have concomitant renal disease, coronary disease, and so on and so forth. So you have to really be careful with the dye use. Again, you see, if you watch my hands, for people beginning, you want to fix your right hand, left hand to right hand. Do not push the wire, because this filter is attached to the wire, and if you push the wire, the filter will move, and therefore will also possibly spill its debris. Is he okay, Liz? So.
Dr. Christian, this patient had what, 2 vessel runoff or 1 vessel runoff? What was it?
Single vessel runoff.
Single vessel.
Okay, good. He's doing fine. We have wonderful nursing and wonderful techs and incredible support in this lab, so it's really easy for us to do a high number of cases quickly. Now, I've gotten everything done. Now I'm going to give a little more dye because I really want to check this filter because it could have gotten full again. So I'm going to have Ray inject, and I just want to see the filter very, very carefully. And as it comes, we hope it comes anytime soon. There it is. You can see that, I got to take a better picture. You need more dye, right?
So, Dr. Christian, the filter extends from the loop to the tip of the catheter distally, or from where to where?
Exactly. Exactly what you described. You can see you have something inside
there's something
that filter.
There. Yep.
You see that?
Yep.
Now, that is a nightmare. If that goes downstream, You know, that could have happened when we ballooned. It could have happened. It could be clot that formed. It could be anything. If that goes downstream, now you're in for a world of pain, you know. So as, you know, you really want to make sure that you want to avoid this by anticipating the potential.
So how are you going to take care of it?
Now this is not overwhelming the filter. So we can capture this filter and bring this out safely without overwhelming the filter. So now what we're going to do is we're going to go with the capture device. We're going to go with the which comes with the kit, obviously. It's a monorail system, so it helps us a lot, so we don't have to move it too much.
Do you do partial capture or complete capture of the device?
You know, as long as you get the loops in, you're fine. You know, and I think the advantage of this particular device, with the ease of application, especially through the Trailblazer catheter, really helps you. So, you know, it saves you steps. You know, you can actually introduce this device through the Trailblazer catheter. I've also introduced it through the Cordis Aqua Tempo catheter with the 4 French. It fits really well. So whatever device you cross the lesion with, you just put the filter through and deploy it. Because we thought we were going to run out of time, we didn't want to show you that step. So I'm going to keep Ray to focus on this. I'm going to keep the filter in my picture, and I'm looking at the camera, the monitor above the camera. And you can see here that as the filter comes down, you don't want to ram it in the capture device. So it's going to come, so you want to be a little slow as you get closer. I'm having no resistance. I'm not getting caught in any struts. And I know it's going to come anytime soon. This is sort of like giving birth. You know, you're waiting. And sooner or later, it's going to happen. There it is. OK, you're there. Now come down a little lower. So here it is. So now, what you want to do, unlike other filter devices, in the Abbott filter, you actually pull the filter into the catheter. In the EV3 device, you actually fix the wire on the filter and sheath the filter. So extremely important, and this is where sometimes you may get some movement, but as long as you're careful, it should not be an issue. So I'm really fixing it hard, and now you can see I'm capturing it very slowly. Now I've got full capture. I mean, I can go down further, but if I go down further, I may squeeze some of the stuff out.
So I have a partial capture.
Yes, it's a partial capture, exactly. So I'm going to just hold it up to here. Now it's very important to fix the wire. So I'm going to fix the wire and the filter. I'm going to have Ray just follow it up. It's going to make you guys dizzy. So I'm going to follow it up slowly. Get all the way up. All the way up. Again, you want to watch it because sometimes you can get caught in a strut. And if it's caught right there in the strut. So you want to be extremely careful with these particular devices. Good, I was able to jimmy it free. And you want to bring it back into the sheath. Now I'm safe. Now I'm going to pull it all the way out. And now what I'm going to do is I want you to show my hands here. I'm going to go ahead and bleed this out, okay? A couple of cc's of blood doesn't hurt, okay? You want to bleed that out. So now this way, if there's any clot inside the catheter that might have leaked out, we'll go ahead and do it. And then we're going to go ahead and suck back 10 cc's of blood. Now I'm going to come forward with some saline. Okay, that's good. And then we're going to flush forward. So we're going to clean this out. So I think we're pretty much done. God willing, we have no embolism, and we'll be done, and everybody will be happy, and patient will do well as well.
Dr. Christian, I'm not a believer until I see the final results. You're going to show us a picture of the distal foot to see if there's any distal embolization?
I would be remiss if I didn't do that, Dr. Wiley. One of the things that we teach here, you and me, is very important to have discipline and geography. And discipline and angiography means obviously inflow as well as outflow before as well as after. You obviously don't want to open an artery and trash the foot, so it's extremely important. So Ray's just going to take a little dive for us. Good. Now we're going to go ahead and we're going to inject. 1 second. You okay? Okay, good. Oh, that was a little too early. So we're going to go ahead and inject now. So we still have a little bit of lesion there, but I think overall the flow is very good. Right there, I'm very happy with that. Now that's the Foley catheter that you see across. Now we're going to go down to this level and show you. I'm going to go a little bit lower here.
Dr. Christian, we have a online question. Is the filter smaller than it should?
A filter what?
There's a question that was sent to us. Is the filter smaller than it should, or you think it was appropriately sized?
Is the filter small? No, but see, the point is the largest filter available, I believe, is around a 7 with the EV3, right, Ricky? It's around a 7. So, you know, that popliteal is probably around a 5 to 6 millimeter vessel. And if you go C- here, I'll show you. you can see that the filter was very well opposed. You see that? When we gave dye, you'll see that the filter was well opposed. You could check it in two views if you're not sure, but here the filter is extremely well opposed against the vessel. And it also reflected with what we captured within the filter. Mm-hmm. Obviously, you are probably going to have some micro, embolism that occur. We know in carotids also that occurs, but the question of clinical significance is what I worry about. Here, the clinically significant embolism is the embolism that we have caught inside this bag. If that had gone down, it would have clearly shut that anterior tibial, which is open right now. And now I'm just going to take one good shot of the foot. Inject, and I think it's important to size it properly. Do you need to measure? I think in the beginning you probably do, but then later on, as you get a little more experience, I don't think you really need to measure. So we're taking a picture now.
There's the money shot.
And you see right there, there's the vessel coming down, all the way down, beautifully into the foot. And I think there's no change. Obviously, there's slow flow, and I think the slow flow is because of diffuse microvascular disease that occurs. The guy obviously had very poor flow before, and this will improve a lot. We'll obviously keep him overnight. We'll go ahead and now probably maybe work him up, make sure he's not having any ischemic issues. I think he is. EKG was normal. We'll keep him on the floor, hydrate him. We've now given a total of 60 cc's of dye, and that's it. I think we're pretty much done. Other options of treating in-stent restenosis, just to go over the last few minutes. Obviously, you can just do balloon angioplasty, leave it alone. You can do repeat stenting, which I know a lot of people do. You can do covered stenting, which I think is also possible in these particular types of cases, to go ahead and line this with a covered stent. And I think obviously you can just leave it alone and do a bypass, or just leave the patient with claudication. I mean, this is a very frustrating thing that we have to deal with. I think as the newer devices come out, and as we have more devices to use with drug-eluting balloons and drug-eluting technologies, debulking followed by drug elution, who knows what the future holds, but I know that there is improvement in the horizon, and I'm heartened by that. But at this stage, I just want to make sure, I shouldn't say heartened, I take heart in that. At this stage, I just want to go ahead and say that whatever you decide to do, you want to be able to predict the complications that may possibly occur. You want to take the steps ahead of the complication occurring, and you want to place things such as a filter, do things such as rotational atherectomy with the Jetstream device, directional atherectomy with Silverhawk, or balloon stenting. Does not matter. Try to predict what you expect to happen, and I think you'll have a very good outcome. So reasonably complex case, a lot of talking points. Within 1 hour, we're done. I'm very, very happy. Patient is good. I'm feeling well. I'm sure the staff here is good. And I think we're going to let you go here, Dr. Wiley. I really appreciate you moderating this session. Dr. Dangus, unfortunately, had to be away today. We miss him, but he'll be back next month. I also want to tell everybody out there that the content is being updated on the website. We've got articles. We've got a case of the month that's going to go in starting this month. We've got everything done starting in June. I also invite you wholeheartedly to our symposium. We have a cardiovascular symposium. Dr. Sharma has been doing it for many years. The vascular side has been live for about 5 years now, or 4 years. I can tell you that in that one day, you're going to see not only complex carotid, you're going to see 2 live carotid cases, one with proximal protection, one with distal protection. You're going to see a first live renal denervation case that's being transmitted to the New York area from Germany. Our good friend Dr. Zeller is going to do that, which is, again, I think phenomenal, because I think that's going to be a lot of things that we're going to be doing in the future. We're dealing with a difficult case of renal, which I think is going to bring a lot of thoughts. We're going to do an upper limb case, and obviously we're going to do a complex below knee case. So in one single day, you pretty much are going to cover the entire body with the exception of the iliacs and intracerebrally. So I think it's very exciting. We've got a wonderful panel of people, all world experts coming. And we all of us here at Sinai really wholeheartedly invite all of you to come and really join us. And I really appreciate your patience and your time. Thank you.
Dr. Krishna, I commend you for a very well done case. Once again, we invite you to the 15th Annual Complex Coronary and Vascular Case Symposium on June 13th to the 16th at Mount Sinai Hospital in New York City. For registration, once again, is cccsymposium.org. If you miss any previous live webcasts, you can still view them on the website. Just go to Archive Cases, which is the link on the top of the page. We'd also like to mention that our last month educational video titled Management of Iliac Artery Disease is also up on the web, and you will be able to see as well. Thank you.